So today's topic is about ACL tears. They can either be a subsynovial or an avulsion tear, single bundle tear, or a total rupture, that is double bundle tear. So you can see it in males and females. Female athletes is also it is common. What will happen is that when there is a force, when the knee is at valgus and hip is at adduction on landing on the ground, it can either be due to the direct blow to the lateral knee or a non-contact pivot injury. There is a tibia just translates anteriorly while the knee is in flexion and valgus. This is seen in a soccer players, basketball, skiers, football. It is associated normally with a meniscal injury, mostly a lateral meniscus injury, a PCL and LCL. Chronic tears are associated with a medial meniscus tear and any chondral injuries associated. Okay, a bit about the anatomy of ACL. ACL is 32 by 12 mm length and width. There are two bundles, anteromedial and posterolateral. Anteromedial is an isometric tight inflection and is helpful in anterior tibial translation. Posterolateral have some length changes during movements. There are tight in extension and it will give rotational stability. Attachments are femoral attachment to the lateral intercondylar ridge. Tibial attachment is between the anterior intercondylar eminences. Composition is 90% of it is type 1 collagen and 10% of it is type 3 collagen. Blood supply is through middle geniculate artery. Nerve is the posterior articular nerve, which is a branch of tibial nerve. So when there is a tear, there will be a history of deep pain, difficulty in weight bearing, swelling, hemarthrosis, instability, a pop feeling again and again. On examination, you will find a effusion, quadriceps avoidance gait, a varus deformity if present, and associated various injuries like ligament injury, meniscus injury, any neural or ligament deficits. So what tests will help you? Anterior draw test, Lachman test and pivot shift test. Grades are 3 to 5 mm, 5 to 10 and more than 10 mm translation. Lachman test is false positive in a PCL tear. That is because tibia is posteriorly subluxated and when you pull it forwards, they will have a false positive. A pivot shift test where the knee is in extension and then you slowly flex it with the valgus and internal rotated knee. Nicely done in an anesthetized patient. Then you will take an X-ray, AP, lateral and a sunrise view. In AP you have to exclude a Segons fracture, and in lateral you will see a deep sulcus sign in the distal femur. On MRI on the sagittal planes you will see a discontinuity in T2 images. It can either be very too flat or angled or it is not visualized. There can be a bone bruisings or an eversion fractures. Here ACL is usually in line with the intercondylar line parallelly. On a coronal plane, you will see a discontinuity and an empty notch sign, that is a fluid against a lateral wall. Okay, then treatment. First, you will go through a conservative treatment if there is not much instability and very low demand patients and old patients in whom surgery cannot be done. In young active males or in children's or in a high demand athletes and people who have high instability and already there is a one time reconstruction done and failed, there you will opt for surgical procedure. This is done through arthroscopy. You can also do a single bundle or a double bundle. Single bundle is commonly done. So for this procedure, first you will make a femoral tunnel placement which is transtibially or through the femur. Sagittally, you will take a 1 to 2 mm rim of a bone between a tunnel and the posterior cortex of a femur. Coronally, you will go at a lateral wall at 2 o'clock position for the left knee and 10 o'clock position for the right knee. You will create a horizontal graft to decrease a rotational laxity. Then you will drill by putting the knee in 70 degrees of flexion, which will prevent the posterior wall blowout, which is a common complication here. Then you will go to tibia tunnel. Tibia tunnel sagittally you will see that it is 10 to 11 mm in front of PCL insertion, 6 mm anterior to the medial eminence and 9 mm posterior to the intermeniscal ligament. Okay, and coronally you will see it is less than 75 degrees from the horizontal. That will help in the tunnel trajectory. You will be between a tibial tubercle and a posterior medial edge of tibia. Then you will place a graft by putting the knee in 20 to 30 degrees of flexion, and preconditioning of the graft is required to decrease the stress relaxation. This can help up to 50%. Then you will fix the graft either all inside suspensory fixation or a combination with the interference screw. Interference screw will give a compression fixation. Cortical buttons will give you suspensory fixation. Screw and washer post is also done suspensory fixation, or a staple put, that is also suspensory fixation. What are the grafts which we can use? Quadrupled hamstring autograft, bone patella tendon bone autograft, which is gold standard, quadriceps tendon graft, and allografts like fresh frozen or irradiated or a drip freezing or a 4% of chlorhexidine gluconate. Then you will start early rehab. First you will give saphenous nerve block, then ice, immediate weight bearing to decrease the patellofemoral pain, and early full passive extension. Early rehab is done and don't stress upon more on the graft. Eccentric strengthening at 3 weeks to increase the quadriceps strength and volume. Isometric hamstrings, isometric quadriceps, 35 to 90 degrees flexion. After 9 months, you can start playing by hopping. Isokinetic quadriceps strengthening at 15 to 30 degrees is done in later date. Complications can be intraoperatively, there can be a graft tunnel mismatch or a posterior wall blowout or a tunnel coil position. There can be inadequate graft fixation, improper rehab given, intraarticular femoral plug, bone plug dislodgement, any infections, any loss of motion or arthrofibrosis, any contraction syndrome, CRPS, tunnel osteolysis. Patella can have a fracture or a patella tendon rupture or a late osteoarthritis.